Today's moderator is Dr. Aditya Vikram, and our senior coordinator, Dr. Pavani, and our academic chairman, Dr. Deepraj, and a very important person, Dr. Veeresham sir, President, ISA Telangana is here. So now I request Aditya to take over and start. Thank you.
Thank you, sir. Good evening to all. So continuing with our education streak of making awareness more on the pro, getting in stream with the postgraduate. So because we have covered in our first topic shock, and then we had topic of vasopressors and inotropes. So one more important concept of the sepsis and the sepsis bundle, or the increased number of patients who are actually having increase in the morbidity and mortality before COVID, during COVID, and also after COVID will be sepsis. So that is the most important topic, which every one of us at some point of the time, either as a MBBS graduate or a postgraduate or a practitioner, will have to face in day-to-day life. So it's going to be a very interesting topic, as well as practical important topic that we all will face in some form or the other. So refining our knowledge and tuning us back to the basics, as well as the latest advances in today's sepsis bundle and today's sepsis guidelines, how to interpret our ICU reports and other things. We have 2 lectures now. The first lecture will be on the sepsis and the sepsis bundle by Dr. Srikanth. Dr. Srikanth is an ISA executive member for Hyderabad, as well as the state executive member for the Indian Association of Pediatric Anesthesia. He has been practicing both ICU as well as anesthesia. He is MBBS from Kakatiya Medical College, as well as anesthesia from my college. He has vast experience. He leads ICU as well as OT. He is head of the department at the Shalini Hospital, Katpura. So he will take us through the sepsis as well as the sepsis bundle. What are be done? What are the evidences? And what has changed from the last sepsis bundle in 2016, 2018 to 2021? What are the guidelines? What are the modifications? And what are the changes? So with this, I introduce and welcome you to Dr. Srikanth. Over to you, Srikanth.
Good evening, everyone. Thank you, organizers, at the outset for giving me a chance to speak here. Hopefully, I will make justice in whatever I am telling you right now. So today, my topic will be on sepsis and sepsis bundle. So sepsis and septic shock, it is a medical emergency, and it is a major healthcare problem. Just a second. Yeah, and it is a major healthcare problem which is affecting millions of people around the world each year and killing as many as 1 in 4 or more. It is something similar to the myocardial infarction or stroke or polytrauma patients, where the mortality is very high, but unfortunately it is very much underestimated and under-recognized. So the early identification in these kind of patients and appropriate management in the initial hours after sepsis, it improves outcomes. The problem with underestimation and underdiagnosis is because of the lack of definition of sepsis in particular. There has been various changes to sepsis definitions. This is the latest definition of sepsis, which is called the sepsis 3. I'll tell you the difference between the sepsis 2 and sepsis 3 after this. So sepsis is actually defined as a life-threatening organ dysfunction, which is caused by a dysregulated host response to infection. And septic shock, it is a subset of sepsis with circulatory and metabolic dysfunction and is associated with a higher risk of mortality. Now, what is the difference between sepsis 1, 2, and 3? As I told you, there have been 3 definitions of sepsis, and sepsis 3 is is the better among all these 3. In sepsis definition, in initial sepsis 1 and 2, it was presumed it was given as a SIRS, wherein infection with 2 or more criteria for SIRS. Unfortunately, in most of the patients with sepsis, not all SIRS features are identified, though they might have an organ dysfunction. And in all the cases, sepsis have been classified into sepsis, severe sepsis, and septic shock. But there is no classic differentiation going from sepsis to severe sepsis and septic shock. It is just a continuum. Sepsis cannot be divided into sepsis and severe sepsis and septic shock. So the latest definition of sepsis, it includes only a sepsis and septic shock, wherein in sepsis it is a organ dysfunction should be present. Either can be an early organ dysfunction or a severe organ dysfunction. It does not categorize into those kind of things. And in septic shock, there should be a circulatory disturbance or an increase in lactate levels. So this helped in a better diagnosis of the sepsis and better treatment of the sepsis. Now, how do you identify sepsis? Unfortunately, it is basically sepsis being a dysregulated host response. There are no clinical measures which can identify this dysregulated host response. It is only based on clinical examination and lab parameters wherein we can identify sepsis. But there are a lot of scores which tells us about the organ dysfunction, and they predict mortality in a patient with a suspected infection. So SOFA scoring is one among the system. SOFA scoring incorporates a lot of variables which include the CNS, CVS, respiratory, the platelet levels, the bilirubin level, as well as the renal function. A lower score of SOFA predicts a better outcomes, whereas the higher scores predict a worse outcomes. So how do we define organ function based on a SOFA scoring? Assuming the patient to have a initial SOFA scoring of 0 with no pre-existing disease, any acute change in a total SOFA score of 2 or more than 2, we can say that the patient has some sort of organ dysfunction. So that is how SOFA is actually interpreted, and a score of 2 in a SOFA characterizes a 10% mortality. So that's how severe a SOFA scoring of 1 or 2 becomes. Now, what are the symptoms of sepsis? Sepsis, the symptoms in sepsis are very non-specific. They range from a wide variety of symptoms like confusion or disorientation, shortness of breath, tachycardia, tachypnea, cold clammy skin, fever, nausea or vomiting. These are very non-specific. We can see in any kind of disease. So a clinical judgment is very important in identification of sepsis. Now coming to the bundles. Basically, this is sepsis guidelines are given by the Surviving Sepsis Campaign, wherein people sit for every 4 hours and they update the bundles accordingly. The first sepsis campaign, the first guidelines were given in 2004, and from on every 4 years, these guidelines have been revised. The latest guidelines have come in the 2021. Initially, in the 2016, they have given a 3-hour bundle and a 6-hour bundle. These bundles are nothing but a set of treatment things which needs to be done in a particular time frame so that we have a better patient outcome. But later on in 2018, it has been recognized that this 3-hour and 6-hour bundle is a long duration, and the mortality of the patients has been on a rise even with incorporation of these bundles. It has been understood that sepsis and septic shock is a medical emergency which needs to be started immediately. Hence, the 3-hour and the 6-hour bundle has been clubbed together and formed a 1-hour bundle. So 1-hour bundle is nothing but the time from the recognition of sepsis. Within 1 hour, there are a few actions which needs to be finished, which needs to be initiated for a better outcome of the patient. There are 5 components which are being incorporated in this 1-hour bundle. Among those are measuring the lactate levels and remeasuring of the lactate if the initial lactates are high, which is more than 2 millimole per liter. Second thing is to obtain blood cultures before administering antibiotics. Third is to administer broad spectrum antibiotics. Fourth, in the event of any hypotension or hyperlactatemia, administration of 30 ml per kg of crystalloids. Fifth is to initiate vasopressors if the target map of 65 millimeters of mercury is not met even after fluid resuscitation. So this is the 1-hour bundle which needs to be started immediately within the first hour after recognition of sepsis. Though these things might not be completed within 1 hour, the whole concept here is to start the treatment for sepsis. Like the 30 ml per kg of crystalloid cannot be given in a period of 1 hour. It takes time. It needs to be finished in a particular period of time, which we'll talk later. The whole concept here is to recognize the early recognition of sepsis and the start of a 1-hour bundle within the first hour of the recognition of sepsis. Now let us go into each of these 5 components into a little more detail. Coming to the lactates. Lactates, these are an indirect measure of tissue perfusion. Unfortunately, lactates not only are elevated in sepsis, they are also elevated in other issues like liver failure. But there have been several studies which have shown that elevated lactate levels have an increased mortality, and hence lactate guided fluid resuscitation is better than ignoring lactate or taking into consideration the physical examination or based on the urine output. So these resuscitative measures lack a these are all subjective or objects of these are all subjective. Hence, lactate being a laboratory investigation, it is better in measuring going with the lactate for fluid resuscitation. Next, coming with the infection control. Infection control incorporates two things. One is starting the antibiotics and the source control whenever there is a particular source which you have identified. Now, in which subset of patients we need to start antibiotics and what antibiotics to start? Earlier in the previous guidelines, in the 2016 guidelines, they used to say that you need to start antibiotics within 1 hour in patients who are diagnosed as sepsis or septic shock or with septic shock. And the coverage of antibiotics should be such that it incorporates all the organisms like the MRSA organisms, the multi-drug resistant organisms, the fungal and the viral. But in the latest definitions, in the latest guidelines, the guidelines say that whenever there is a septic shock or when there is a definite probability of sepsis, the antibiotic needs to be administered within 1 hour. In other cases, like when there is no septic shock or when there is a possibility of sepsis, you need to investigate further, do a rapid investigations to investigate further, and if still the concern for infection persists, then antibiotics need to be started within 3 hours. In patients with absence of shock and low likelihood of sepsis, we need to defer antibiotics and closely monitor the patient for any further deterioration. So this is what needs to be done with antibiotics. These are the revised guideline in the 2021 compared to the 2016. Now, what kind of antibiotics these patients need to be started? Sorry, not all the patients should be started on antibiotics where you cover all the organisms like the MRSA, MDR, fungal, or the viral. The latest guidelines say when a patient, if you suspect a patient to have an MRSA, then you need to start an antibiotic which also has an MRSA coverage. If there is a low suspicion for MRSA, start an antibiotic without an MRSA coverage. Similarly, with MDR organisms or the multi-drug resistant organisms, you need to start with, if you have suspicion for MDR organisms, you need to start with 2 gram-negative coverage antibiotics, whereas if there is a low suspicion, the 1 gram-negative coverage is sufficient. Similarly, with fungal infections, if there is a high suspicion for fungal infections, as an example, in patients with high risk for fungal infection like severe immunosuppression, the patients on TPN, on steroid for a long-term use, those patients need to be started on empirical antifungals. If there is a low suspicion for fungal infection, then antifungals need not be started. These guidelines do not give any clue regarding the viral infections. And always cultures need to be started before starting antibiotics. Now coming to the source control. Whenever you identify a source, controlling the source is paramount. They help in better penetration of the antibiotics and early recovery from sepsis and de-escalation. So once the source control is made, the antibiotics need to be given for a short duration of period compared to the long duration. Lots of studies have shown that short duration of antibiotics is sufficient for control of sepsis rather than giving for a long duration of time. And based on the culture reports, de-escalation of antibiotics need to be done. And also daily evaluation of antibiotic de-escalation needs to be done. And there are a few antibiotics wherein, based on its pharmacokinetic features, there are beta-lactams which need to be given over a period of time, which have a pharmacokinetics wherein a level needs to be maintained in the body. So a continuous infusion is preferred over short boluses. Whereas in the other class of antibiotics like the fluoroquinolones, aminoglycosides, you need to give a bolus dosing so that their action persists whenever there is a high dose of drug in the body. So based on the pharmacokinetics also, you need to adjust the dosing and the duration of the antibiotic. And whenever there is a doubt in for de-escalation, you can use procalcitonin as a marker for a de-escalation of antibiotic. But whenever there is a strong suspicion of sepsis, these guidelines suggest against the use of procalcitonin for diagnosing sepsis. Now coming to the hemodynamic management. As we have already discussed earlier, whenever a patient is in shock, the hypotension or hyperlactatemia being more than lactates being more than 4 millimole per liter, a fluid of 30 ml per kg should be instituted within the first hour of recognition of sepsis and should be given within the first 3 hours. Now, what kind of fluids need to be given? balanced crystalloid solutions are the preferred fluid of choice over saline or other colloids like starch or gelatin. This is a change from the previous guideline where they have suggested either balanced crystalloid solutions or saline for initial resuscitation. They have also suggested gelatin in the previous guidelines for resuscitation, but these guidelines suggest no role of starch or gelatin as they have a harmful effect on the kidneys as well as hemostasis or gelatin with hemostasis for hemostasis. Now, albumin can be given in patients who have received large volumes of crystalloid, not as an initial fluid, but in patients who have received large volumes of crystalloid, albumin can be given because it stays in the intravascular space for a longer period of time. And the whole purpose of this fluid management is to maintain a target map of 65 millimeters of mercury. There have been studies which have shown where they have targeted a higher map of around 75 or 85, but a map of 60, they have not shown any substantial benefit over a map of 65 millimeters of mercury. Targeting a higher map requires higher volumes of fluid and the vasopressors, but in the absence of any benefit, map of 65 is recommended. And if the coming to the vasopressors, if we are not able to maintain a map of 65 millimeters of mercury, you need to initiate vasopressors early, either during the fluid resuscitation or after the fluid resuscitation. The vasopressor of choice being norepinephrine, which is the first line of drug. And when the norepinephrine dosage requirement is increasing, instead of increasing the dose of norepinephrine, vasopressin needs to be added. There is adrenaline can also be added in the case of worsening of septic shock. In certain situations where a septic shock is associated with cardiac dysfunction, dobutamine can be added to norepinephrine, or directly you can start the patient on adrenaline. And whenever your fluid resuscitation is done, dynamic measures like passive leg raising test, stroke volume variation, pulse pressure variation, and echocardiography, these are the dynamic measures which needs to be seen for fluid resuscitation over static measures like CVP or heart rate. Capillary refill time is a newer addition in the latest guidelines. And after initial resuscitation, whether to continue with the fluids or not, there have been insufficient evidence in the latest guidelines. They did not advocate either a restrictive fluid strategy or a liberal fluid strategy in patients who still have signs of hypoperfusion or volume depletion. So based on the clinical judgment, you need to proceed further, as there have not been any clear-cut guidelines, because of late there has been a lot of talk on restrictive fluid strategy. But after initial fluid resuscitation, if patients are still there are signs of hypoperfusion, the guidelines do not give a clear picture regarding this. And invasive blood pressure monitoring is preferred in patients who are on vasopressors. And whenever a vasopressor is started, it is preferable to start them on a central line. In the absence of a central line, we should not delay starting the vasopressors, and these need to be started in a peripheral line. Preferably, the peripheral line should be proximal to the antecubital fossa. As you can see here, for patients with septic and septic shock on vasopressors, norepinephrine is the first line vasopressor, and a target map of 65 millimeter mercury needs to be maintained. Consider invasive monitoring of arterial blood pressure. Consider initiating vasopressors peripherally if the central access is not yet available, and consider adding vasopressin if the map is not able to, if you are not able to maintain map with norepinephrine. Adding dobutamine in cases of septic shock with cardiac dysfunction. Now coming to the ventilation targets. Use of a conservative oxygen targets. What are conservative oxygen targets? Targeting a PO2 of 55 to 80 and an SpO2 of 88 to 92. A lot of studies have shown a better outcome in patients who have been maintained with a conservative oxygen targets. There are also few studies which have not shown a particular benefit in when we have used a liberal oxygen targets, like higher oxygen targets compared to the conservative oxygen targets. So lower the better, because we have a better outcome, and their outcome is not inferior to the higher oxygen targets. In sepsis with sepsis-induced hypoxemic respiratory failure, high flow nasal oxygen is preferred over non-invasive ventilation. This is purely because the patient is more comfortable with high flow nasal oxygen compared with the mask, which can cause pressure ulcers, a tight fitting mask patients will not be able to communicate, patients will not be able to eat, not be able to phonate properly. Whereas these things are avoided in high flow nasal oxygen because the patient will be comfortable. But keep in mind, this is only for hypoxemic respiratory failure. Whenever there is a hypercapnia associated, high flow nasal oxygen will not work here. And in patients with sepsis-induced ARDS, low tidal volume ventilation is preferred over large tidal volume ventilation, and a plateau pressure needs to be maintained below 30 centimeter water. And in sepsis-induced ARDS, higher PEEPs are recommended compared to the lower PEEPs. In moderate to severe ARDS, prone ventilation for more than 12 hours is recommended. Coming to the neuromuscular blocking agents, in the previous guidelines, a 48-hour neuromuscular blocking agent needs to be. They said that we need to give a 48 hours. The patient should be under paralysis using a continuous infusion. But the later studies, they recommended intermittent neuromuscular blocking agents over continuous infusion, as they have not seen much of a difference between these two things. But whenever boluses are given, we need to see that the patient is completely sedated. In the case of failed mechanical ventilation, veno-venous ECMO is preferred. Now coming to the additional therapies. After this infection control, the lactates, the hemodynamic management, and the ventilator management, there are some additional therapies which help in a better outcome of the patient. Additional therapies include corticosteroids in cases of refractory septic shock. This is a clear change from the previous guidelines. In the previous guidelines, there have been recommendations that corticosteroids should not be used when we are able to maintain a mean arterial pressure, or when we are able to maintain a mean arterial pressure of 65 millimeters mercury with fluids and vasopressors. But the latest guidelines say, even if you are able to maintain mean arterial pressure with vasopressors or fluids, or if the vasopressors requirement is for at least 4 hours, at least a dose of 0.25 mic per kg per minute, you need to add corticosteroids at a rate of 200 mg per day, or as 50 mg boluses every 6 hours, or a continuous infusion. There are also few studies which are wherein blood purification techniques have been used for early recovery from the sepsis. The latest guidelines do not give any suggestion regarding the use of those techniques. In fact, they do not suggest. There is not a recommendation, but they do not suggest any blood purification techniques. Patients with higher risk for GI bleed, stress vessel prophylaxis is needed. If there is no risk for GI bleed, stress vessel prophylaxis is avoided. VTE prophylaxis is indicated in all patients unless contraindicated. The pharmacological prophylaxis should not be, there should not be any addition for pharmacological prophylaxis in the form of mechanical VTE, as it is not shown to be of any benefit. Coming to the renal replacement therapy, a lot of people have been initiating lot of studies wherein early renal replacement therapy has been shown to be beneficial. But according to the guidelines, recently published guidelines, they say early renal replacement therapy is of no benefit unless and until there are definitive indications for the RRT, which include uremia, refractory acidosis, refractory fluid overload, and hyperkalemia. Just because a small rise of creatinine or for a short duration there is no urine output, initiating RRT is not indicated. Coming to the blood glucose levels, insulin therapy needs to be initiated only when the blood glucose levels reaches more than 180 milligram per deciliter, and the target for blood glucose level should be between 140 to 180 rather than a lower target, as patients might go into severe hypoglycemia. And the latest guidelines, there is no role of vitamin C. Coming to the soda bicarb, sodium bicarbonate should not be used in patients to improve hemodynamics or to reduce vasopressor requirements. Soda bicarb is only indicated when there is a severe metabolic acidosis and AKI stage of 3 or 4. And early enteral feeding should be started in patients who can be fed enterally, preferably within 72 hours. Either a hypocaloric feeding is also beneficial. Coming to the long-term outcomes and goals of care, this is very important as the patients, because sepsis being a burden, it is a burden both physically, emotionally, and as well as financially. The attenders needs to be counseled properly, and their consent should be taken, and they should be taken into confidence, so that it will be a better outcome for everybody. Because as you know, as you have seen, this is a major healthcare problem, killing almost 1 in every 4 or more patients. So such a medical emergency and high fatality rate, the patients and their families needs to be taken into confidence whenever we are treating these kind of patients. The goals of core care and prognosis should be discussed with patients and families. Based on the clinical judgment, principles of palliative care into the treatment plan should be included where you feel appropriate. In survivors of sepsis, they should be referred to peer support groups who have long-lasting disability, and the families need to be screened for economic or social support, and referral should be made where available to meet these demands, as sepsis will take a long time for the patients with sepsis will take a long time for recovery, and financially it is difficult to sustain in our country, in scenarios like our country where the insurance is lacking. And there should be a shared decision making in following up the patients in the following up of the patients for the post discharge and all. So concluding, sepsis and septic shock is a medical emergency. Early identification and early initiation of treatment is paramount. Strict adherence to the 1 hour bundle and performance improvements and programs needs to be done so that adherence to the 1 hour bundle is maintained, and discussing long-term outcomes and goals of care with patient and patient attenders. Thank you.
Aditya, shall we take the
Yeah.
questions at the end of second session, or shall we finish now?
Now, sir.
Very nice presentation and brief and informative.
Thank you, sir.
Questions?
Yes, sir.
Questions?
So it was a very concise presentation. Any questions so far? Nothing in the chat box, but I think we'll take it later on. So it was a good, concise presentation, and more important, now it's a time, because as you all might be aware, that anesthesiologists are being forced not to be appearing for critical care. Not that we are not being made to appear for the critical care, but more important for us, when we say we manage the ICU, we need to know how to adapt and interact in a more meticulous way in approaching this never-ending solution to a problem called sepsis. So taking it forward, we have a very interesting topic. Like what we all say is your eyes can only see what your mind knows. So important is we have so many investigations today. There are umpteen number of investigations that we can advise or prescribe to a patient, but interpreting it in the right way and using it in your treatment, either to escalate or de-escalate a treatment, is of utmost and paramount importance. So taking us through this topic of how do you read a culture report in the ICU, how do you interpret the culture report and antibiotic sensitivity report, we have Dr. Pratik Patil, who is a consultant at the KIMS Hospital, Secunderabad, for the infectious disease. He has done his MBBS from the TN Medical College, Mumbai, as well as his DNB from the Kerala Medical College, Trivandrum. And then he has done his infectious disease course from the Apollo Hospital, Chennai. He's a very enthusiastic guy, very dynamic, and he has been spearheading the ICU, especially in case of transplant issues where they are forced with infections. So where everyone stops, Dr. Pratik starts. So I hand over the mic to Dr. Pratik. Welcome, Dr. Pratik.
Thank you, Dr. Aditya. So yeah, today we will discuss how to analyze the culture report. So cultures are common practice for all of us in the ICUs and all the infections. What we see, we send the cultures and we see quite positive number of cultures. So, but what is the right way to interpret it and analyze it so that we can make most of it for the patient outcomes? So I'll just start with the case discussion here, and then we can go a bit into the theory and subsequently again into the case discussion. This is just to have a kind of introduction and set the tone for the next few minutes. So this is a case 66-year-old male, diabetic and hypertensive, known coronary artery disease already. He presented to the emergency room with acute shortness of breath. He had some hypertension. The ECG was suggestive of acute coronary syndrome. However, considering there was a hypertension, the blood culture was sent from the emergency room. So initially, the conventional treatment was started for the ACS, and along with that, the antibiotic was started because possibility of a sepsis along with the ACS. And after 48 hours, this is what the culture grows. So as you can see, this is a blood culture sample, and the organism grown is the Staph hemolyticus, Staphylococcus hemolyticus here. And if you read it further, it is resistant to the penicillins, quinolones, even clindamycin, but sensitive to the linezolid, daptomycin, vancomycin, teicoplanin, and other tetracycline group of drugs, including the cotrimoxazole. Now, the first thing is whether it's a true pathogen or not. So this is how we analyze the blood culture report whenever we need. First, what is the site? Let's say the sample is blood. So chances of this being contaminant are relatively less, but still, it's possible. Now the organism, hemolyticus. In the given context, the sepsis was less likely. And again, ACS was the presentation where this doesn't really fit into, and hemolyticus is there in the skin. That's why probably this is a sample which is contaminated by the skin colonizer. And if you read further, this is a methicillin resistant Staph hemolyticus. Normally, we need not treat this organism at all. So we should leave it alone without any treatment, because this is a contamination while taking the sample. It is not a colonizer in the blood. We cannot say it's a colonizer, but it is a contamination while obtaining the sample. So the only thing that we need to act on this is the person who has taken the sample, we need to educate them again how to take the sample in a sterile way so that the contamination is less. And that's it. We don't need to treat this organism even if it's positive. However, this group of Staph organisms are only taken significant only if there is a repeated culture grown with the same organism. Let us say if you have sent multiple cultures and all the cultures are growing same organism, that's one. Second, if you have an implant, let's say central line, where there are multiple samples taken from the central line or device related infection, that is another situation where you can have these coagulase negative staph or the staphylococcus organisms, which can be a pathogenic or infective organisms. Otherwise, they are mostly the contaminants or colonizers. So this is the crux here, that we need to identify which one to treat or not treat. So let's go into a bit theory. So what when we say the cultures where we obtain, it can be from the sterile sites, let's say like blood, CSF, pleural fluid, pericardial fluid, synovial fluid, and peritoneal fluid. And these are not routinely colonized with bacteria, significantly enough to be identified on a gram stain. And any bacteria detected on a gram stain in a sterile site specimen should be considered significant. Although a negative gram stain does not exclude the infection. So if you are clinically suspecting the infection and gram stain shows any positivity, you have to give it a thought. However, if the clinical suspicion is high but gram stain is negative, you cannot rule out the infection. And for sterile body fluids, the sensitivity of a gram stain may be increased by cytospin centrifugation prior to the staining. So this way we can increase the pickup of the gram stain. Now coming to the non-sterile site, which are basically the anatomic sites in which the colonizing bacteria, which can be a normal flora, may be present. And these are typically the sputum, throat swab, wound swab, and genital swabs. So that's why we need to think again before we treat anything that is grown from these sites. And it all depends on the clinical background, what is the clinical suspicion, and what is the colony count in such specimens. And all these things has to be considered before considering that culture, whatever positive culture, whether it's significant or not. So in these samples, another thing that we need to consider is what is the neutrophilic ratio, or what if there are any epithelial cells. So they usually contain the human cells like epithelial cells and white cells. Like in sputum, we know that if there are a lot of epithelial cells in the per sample, per high power field, more than 25, then we know that it is not a good sample. So we need to look into all these aspects before we jump into the treatment part of the culture. So let's say significant colony count. Let's say in urine, for a significant bacteriuria, it has to be more than 1 lakh colonies. And in sputum, it has to be more than 10,000 colonies to say that it may be clinically significant if there are clinical symptoms to suspect any infection. Now, this is about whether there is a significance or not. Now, coming to the issue of resistance. Now, antibiotic resistance is basically a genetic ability of the bacteria to encode the resistance gene that counterfeits the inhibitory effect of the potential antibiotics for survival. So basically, your antibiotics don't work, in simple words, and it can be through the different genes, or it could be through the inactivation of purine channels, or it could be by the modification of the antibiotic targets and neutralizing antibiotic efficacy through the enzymatic action. These are the different mechanisms of resistance in the different bacteria for different antibiotics. Now, what are the common methods to diagnose the sensitivity testing, or whether particular antibiotic is sensitive or not? So the previous one, or we still use it, but not so commonly, is the disc diffusion method, where there are the antimicrobial impregnated filter paper discs, which are put it in the agar plate, inoculated with a standardized suspension of microorganism, and depending on the zone of inhibition, the diameter, it is decided whether a particular antibiotic is sensitive, intermediately sensitive, or resistant for the given bacteria. Then nowadays, most commonly used are the automated antimicrobial sensitivity systems, such as Vitek2. It is designated to accommodate many drugs on a single panel or a card, and they generally cover the clinically relevant concentrations. So you don't need many manual things; you just need to do it with the machine, which does it automatically. Then this is something called E-strip, which is the MIC gradient strip, or E-test, which is ready to use, but it is a separate E-strip for each antibiotic, and it can be used in selective cases. The broth microdilution or the agar dilution, this is commonly used, or we can say recommended, only in certain antibiotics, such as for the MIC detection of the colistin for the carbapenem resistant organisms, or sometimes for the antifungal sensitivities. But the Maldita of MS, it is even further modified or further advanced system of bacterial identification and sensitivity testing. Not commonly available, but yes, some institutes do have it. This is another new technique of identifying the sensitivities, which is genotypic method, which is basically, it uses the PCR techniques most often. We have seen the multiplex panels, PCRs, or the CARBA-R, which detects the different type of resistant genes in the given sample for a given possible bacteria. However, the benefits are, obviously, it's rapid, it is direct, it is very sensitive, and it detects specific resistant genes which are included in the panel. There can be other mechanism of resistance which is not included, and that's why if the presence or any gene is detected, then it detects the resistance. However, if there is no detection, it doesn't rule out the alternate mechanism of resistance. These are the drawbacks, that the individual antimicrobial agent needs to be tested with a specific assay, and only potential or key resistance genes can be detected, and which are often not relevant to the coincidental mutations. So there can be coincidental mutations, like we discussed, which are not included in the panel. There is a lack of sensitivity toward the patients with latent infection. So you need to have a certain amount of bacillary or bacterial load to get picked up, and it cannot detect if there is the underlying profile of resistance has not been defined in the test. False positive test can be there due to the contamination of the sample. They require expensive reagents and machinery, so it's more costly, and you need a skilled personnel for running this test. Now, coming to the another technical aspect which we need to know to analyze the reports correctly, which is MIC, that is minimum inhibitory concentration. So it means the lowest concentration of an antibiotic that prevents visible growth of an organism on agar or in broth, which is cultured in the lab. It is used to determine whether the bacteria can be inhibited by the drug concentrations that are achievable and at the same time safe in the bloodstream. So if you use a higher concentration in the lab, it can inhibit. However, if you cannot achieve such high concentration in the blood, then it's useless. So it has to be having both. It can be achievable with the safe bloodstream levels, and they describe the susceptibility to a specific bacteria to a specific antibiotic. It cannot be generalized, and this is the important thing. They cannot be interpreted based on the absolute values alone. It is always, if you want to compare it with others, it has to be comparison. You cannot change it between the antibiotics or between the different bacteria. The range tested and the breakpoint for each antibiotic must also be known. So the breakpoint, I'll come to what is the concept of breakpoint subsequently. In general, however, the larger the MIC value, the lower is the susceptibility. This is important thing to understand, that the lesser the MIC compared to the breakpoint, this is important. It has to be in relation to the breakpoint to know the susceptibility of the given organism. Now there is something called MIC 50, which inhibits the growth of 50% of the particular bacteria or fungus species in consideration, and MIC 90, which inhibits the 90% of the bacteria or fungus. Now breakpoint, the highest plasma concentration of a drug that can be safely achieved in the patient. So this is what we need to know in vivo. So, and it defines whether the organism is susceptible or resistant to the drug. So basically, the MIC needs to be lesser than the breakpoint for a particular antibiotic to work in a given individual. So it is derived from the in vitro susceptibility testing, and whether the antibiotic will work, it can work, or it will fail in vivo against a given organism is decided by the breakpoint, as we discussed. Now, these are another few parameters which determine the outcomes of a treatment with a particular antibiotic, which is basically a pharmacokinetic, pharmacodynamic, and there is a combination of both, which is basically a PKPD principle, which gives the relationship between the dose of the drug given and the pharmacological effect, with the concentration of the drug being being intermediately determinant fraction of the patient. Just a second.
Lost the audio.
Just a sec, sir. I think there's some signal
Sorry.
issue.
Yeah.
Yeah.
Okay.
This is online class. It's going on. Come on, come on, come on.
That's okay.
Okay.
That's okay.
So how to interpret the sensitivity, intermediate, or resistance? So if it is less than the breakpoint, it is the susceptible, and in this case, the antibiotic is likely to be effective in 90% of the time. If it is intermediately sensitive, then it may be effective at higher doses, or if the antibiotic use concentrates at a given tissue site of infection. However, if it is resistant, the chances of working is very less. However, again, depends on the antibiotic use, dose use, and the concentration achieved in the given tissue. Sometimes we see this mentioned in the report as susceptibility being dose dependent. It implies that in such situations, you have to use the higher doses to overcome the breakpoint. Now, there are usually two societies or guidelines which describe the breakpoints. One is a UCAST or CLSI. Most of the labs follow the CLSI, but there can be difference based on the antibiotics used or different antibiotics. There are different cutoffs. So, in principle, generally the drug concentrations need to be 4 to 5 times the MIC value to ensure that antibiotic is effective. However, MIC does not necessarily always equate with the in vitro clinical efficacy, and it is important to remember that antibiotic will not be effective if it does not penetrate the affected tissues. let's say the sanctuary sites, which are CNS to penetrate the blood-brain barrier, the eyes, and the prostate. So in these tissues, you need the good penetration of the antibiotic. And antibiotics with high MICs may still be effective if they get concentrated at the site of infection. Let's say in UTI, the aminoglycosides get concentrated. That's why it can be still used even if there is a high MIC. The critically ill patients may have altered pharmacokinetics and pharmacodynamics. That's why you need to use the best possible antibiotic as per the sensitivity. And the MICs are often subjective and may not correlate with clinical outcomes all the time. So this we already described. Yes, so this is another important point to remember, that MIC number for one antibiotic cannot be compared with the MIC number for the another antibiotic. So you cannot, I'll just show you the subsequent reports. And the choice of antibiotics should be based on the MIC, the site of infection, and a breakpoint. So all these things has to be considered. Then only you can choose the best antibiotic for the given condition. Also, you need to consider the safety, the ease of use, and the cost when determining the optimal antibiotic. Just for example, if an organism, let's say it's a Pseudomonas, exhibits a MIC of 1 mg per liter to the ciprofloxacin, this organism is probably characterized by the microbiology lab as being susceptible. However, it's a single agent, probably that cannot be used to treat more serious infections with the organism because of its inability to achieve the adequate concentration at site of infection. Let's say like we said, it's a Pseudomonas, and if it is the bloodstream infection, obviously ciprofloxacin is not so good antibiotic for the bloodstream. It is a bacteriostatic. And let us say the another antibiotic reported is a piperacillin tazobactam. Though its MIC is 4 and the MIC for ciprofloxacin is 1, here piperacillin will be superior because it has a higher concentration achieved in the blood. So this is how we need to assess. Now coming to the different cases. So this is a case 1. So 58-year-old male diabetic. He presented with a fever with chills and low back pain. He has a lumbar spine and paraspinal tenderness on examination. He had hypotension, tachycardia. On the CBC, there was a leukocytosis. So clinically, the diagnosis was vertebral osteomyelitis or a paraspinal abscess, which was subsequently confirmed by the imaging. And this is the blood culture taken during the time of admission. Now, like we analyzed the previous culture, you can see here it's a methicillin sensitive Staph aureus. The important thing is here is the aureus. Staph aureus is never a contamination in the blood. It is always clinically significant. And whenever we see a Staph aureus, we need to look into the different aspects. Like it's commonly associated with skin and soft tissue infections or sometimes the bone and joint infections. Rarely bloodstream infections can be due to the endocarditis. So we need to find out the source for the given Staph aureus. So in this case, it was a vertebral osteomyelitis and paraspinal abscess. That's one. So definitely it is a secondary bacteremia due to the underlying abscess. Now, another thing, once we know that it is a Staph aureus, we need to know whether it's a Staph which is methicillin sensitive or resistant. Now, if you see carefully, there is no methicillin mentioned in the report here, but it's the oxacillin, which is a representative antibiotic for the methicillin. So here oxa is sensitive, that's why it's reported as it's a sensitive. So in such cases, the first generation or second generation cephalosporins are better compared to the vancomycin or teicoplanin. So here in this case, though vancomycin and teicoplanin are sensitive, since the oxacillin is also sensitive, the outcomes are usually not so good if you use vancomycin, though it is sensitive. So for MSSA, the treatment of choice is usually a cefazolin or flucloxacillin, which is available in India. In US, the recommendations, if you see, it's the oxacillin or nafcillin. So even if it's sensitive, we should not use the vancomycin or teicoplanin because the outcomes are inferior. And at the same time, they have the renal toxicity and cost is also involved. So that's some important message here, that MSSA treatment of choice is not vancomycin. So always look into that. Now, once you see a Staph aureus, this is another patient who had a Staph aureus. We need to know what is the clindamycin sensitivity and whether it's resistant. Now here, it's clindamycin resistance reported. There is something called inducible clindamycin resistance. So whenever there is a clindamycin sensitive, we need to see what is the resistance to the erythromycin, because if there is a resistance to the erythromycin and clinda is sensitive, however, it's reported resistance here because of the D-test that is done. You need to know whether there is a D-test done, and based on the report, even if the clindamycin is sensitive, if there is a presence of inducible clindamycin resistance, you should not use clindamycin, because while on treatment, the clindamycin may become resistant. So always talk to your microbiologist, ask them if they have performed this test and what is the result, so that your treatment can be fine-tuned. Otherwise, the treatment may fail. This is the D-test. As you can see here, there is a inducible resistance, and you should not use clindamycin in such situations. Moving to the next case, this is a 65-year-old diabetic presented with the fever with chills and left hip pain with leukocytosis. Again, this is possibly septic arthritis, and this is the blood culture, which is a MRSA. Now, in such situations, now what we need to know is linezolid is sensitive, dapto is sensitive, teicoplanin is sensitive, and vancomycin is also sensitive. So which one to use among these? Or let us say even tigecycline, tetracyclines, and cotrimoxazole are sensitive. So if this was not blood, or if it was just pus sample, probably linezolid could have been used, or even tetracyclines or cotrimoxazole could have been considered. However, since this is a blood sample, this is a bacteremia, this should not be used, because linezolid is a bacteriostatic drug. So that's why in this situation, either vancomycin or teicoplanin has to be used, at least for the clearance of bacteremia, that is minimum 2 weeks. So any Staph aureus bacteremia has to be treated for minimum 2 weeks, and then depending on the source of infection, you need to continue or discontinue the treatment. So in this case, we need to continue the IV antibiotic. Again, the dose of the medications has to be properly adjusted. Let's say if vancomycin has to be used, then we need to monitor the renal function. We need to monitor for the side effects, how the nurses are administering. They administer very fast. The patient may have Redman syndrome, which may be reported as possible allergy to vancomycin. So these are the clinical things that we need to see while somebody is administering vancomycin. Then, especially in cases where there is a bloodstream infection, we need to be doing the vancomycin trough levels to see whether we are achieving the adequate suppression.
Good morning to you. How are you?
Mr. Mohan, can you unmute yourself? Dr. Mohan, please, can you unmute yourself?
Okay.
So, Dr. Pratik, you continue.
Sorry. So this, the case we will
the IT team to unmute
so,
him. Mute him, sorry.
Important, monitor the trough levels. If you are, we are using the teicoplanin. If we are using the teicoplanin, again, the dose, commonly used dose is 400 milligrams twice daily for 3 doses, followed by once daily. But again, if you are dealing with bone and joint infection, or if you are doing endocarditis, the dose, double the dose, that is 12 milligrams per kilogram, 3 doses, and then 3 doses twice daily, then once daily, 12 milligrams. So these are the small things that we need to remember. Now, this is the case what we discussed initially, same thing, that it is the possible ACS, and the Staph hemolyticus is a contaminant here. Now, this is another case. A 30-year-old male, fever, diarrhea, abdominal pain, white cell count normal, eosinophils 0. So this is a classic presentation of a enteric fever or typhoid. As you see, the salmonella typhi grown here in the culture. Now, the peculiar reason to mention this, let's say, we have seen that all the antibiotics are sensitive. Most common antibiotics are sensitive here, including meropenem. So this is important to know that if you use a higher antibiotic, it does not mean the patient will recover faster. So in this case, even the ceftazidime, let us say third generation cephalosporin. So in this report, if one cephalosporin they have reported as ceftazidime, let's say, it means that the same result can be applied to most of the other third generation cephalosporins like ceftriaxone. So ceftazidime is good sensitivity. So better to use ceftazidime than the carbapenems here. Otherwise, we will see more and more resistance. This is kind of an antimicrobial stewardship. This is for in general practice that we should not use higher antibiotics here. Again, it's a bloodstream infection, so preferably we need to use the cephalosporins injectables initially, and then subsequently we can change to the oral drugs when the infection is better. So another thing that labs can do is not to report all the drugs, just report the basic drugs so that the clinicians also don't use it unless there is some other reason. So in such cases, better avoid the carbapenems, though it is sensitive. Next case, it's a 70-year-old female, recurrent UTI in the past, now presents with fever, flank pain. She has a renal angle tenderness. So clinically, she has a pyelonephritis, and she has the risk of resistant infections, probably because she has been exposed to the antibiotics in the past. So as you can see, the couple of days later, the blood culture, it grew the it grew the Klebsiella pneumoniae in the blood culture, and as you can see here, it is a bit of not clear-cut sensitivity. You can see the piperacillin tazobactam being resistant, ceftazidime sulbactam sensitive, the carbapenems are resistant, and many other drugs. Amikacin is sensitive, and if you see further, tigecycline is sensitive, patrimoxazole is resistant, and this is important thing I would want to know. See, this is basically a urinary tract infection. So we need to know the PKPDs of the infection here. So though the tigecycline is sensitive, we should not use tigecycline in this case. There are multiple reasons. One, tigecycline is not good for the bloodstream infection. It has a tissue penetration, so it is ideal drug for skin soft tissue infections and intra-abdominal infections, not bloodstream or urinary infections. Again, it does not get secreted in the urine, so better not to use as a monotherapy. You can use in some cases as a combination therapy, but not as a monotherapy. So the drug which we need to choose here is sensitive, that is sensitive, one, that gets penetrated in the urine. Two. So these are the two important things before we need to consider here. So as you can see here, the colistin is moderately resistant. MIC is less than 0.05. So we have to use colistin here. Another thing to note, polymyxin does not get secreted in the urine. So you need not use polymyxin here in this case, though since it's a bloodstream infection, they have reported. Same time, if it is a urine culture and if it is the same organism grown, the culture report typically will not, in a good lab or in a good microbiologist will not report these drugs. So as you can see in this, since it's a blood, our microbiologist has reported it, but same time urine culture did not show these antibiotics reported. So tigecycline was not reported, minocycline same thing, and the polymyxin. So it should not be reported in urine culture organisms. So in this case, colistin has to be used. Even if it is nephrotoxic, we have to modify the dose and use it. The other alternatives for such multi-drug resistant urinary infections are fosfomycin when sensitive. So you need to tell your microbiologist to run these tests in specific such cases. Another newer antibiotic which can be used in such cases is ceftazidime avibactam, either alone or in combination with aztreonam. Again, you need to specifically ask for the synergy testing with ceftazidime avibactam and aztreonam to your microbiologist. It is not readily available. They need to do it in a different way. So these are the things you need to ask as a clinician to the microbiologist. You need to have a constant discussion with the microbiologist to get the best out of your cultures. That is very important to have a dialogue with the microbiology team. Next case, it's a fever patient who presented with dysuria, abdominal pain without any fever. So this is basically a cystitis. So as you can see here, again, it's a Klebsiella pneumoniae grown in the culture. Here you can see that it is a relatively sensitive organism here to the carbapenems. In such situations, carbapenem can be used. Even quinolone is sensitive, which can be used. Okay, and here, if you can see here, the fosfomycin is sensitive here, so we can use that. So another thing to remember in urinary tract infections is, for cystitis, you don't need a long-term therapy. 3 to 5 days therapy is good enough. Again, why I have mentioned this report is that here they have reported many other drugs. Let's say in this tigecycline should not have been reported. However, it was reported. Same thing here. It's there in the urine, need not be reported. So these are the things we need to know as clinicians. Whatever the lab mentions, we need to be aware what needs to be used because of the PKPD. If we use it, then the treatment may not work. Let's say another case which I had seen. This is a 85-year-old lady, bedbound, fever, and basically she had pus pouring from the Foley's catheter. She had a hypertension, white cell counts were elevated, 30,000. Creatinine was 1.6, and this is the urine culture which was sent. Now she was given empirically meropenem because of she was in a septic shock. So she improved in 2 days by the time the culture report came. If you analyze this report, there are so many errors in the report. And again, this was from one of the good labs. So this is reported as Enterococcus species. So Enterococcus is basically a gram-positive coccus. Meropenem doesn't work for it. So if we believe that this is a possibly pathogenic organism which is causing the infection here, meropenem should not have worked and patient should have gotten worse. But patient has improved here. That's one point. Now look at the sensitivities. It is a gram-positive coccus, and none of these drugs work for the Enterococcus. Amikacin is a pure gram-negative cover. Same thing, gentamicin. It has some gram-positive, but not to the certain extent. Ceftriaxone, ceftriaxone do not have any gram-positive cover. Do not have any cover against enterococci. So here probably that, and same thing here. Quinolones to certain extent they work. Cotrimoxazole doesn't work. So probably here they have entered this wrongly. It could have been Enterobacteriaceae species, some of the Enterobacteria. So this is why you need to know what is the clinical background, what is the treatment you have given. Because if in this case they have not reported even meropenem, but definitely the patient has improved. So you need to analyze your culture reports in a proper way. Now, next case, this is a 55-year-old male with severe COVID. He was intubated. On day 8, he developed a worsening oxygen requirement. He had fever. I'm sorry, there is a typo here. There were new infiltrates on the chest X-ray. So basically, clinically, there is a gap in the given condition. And this was the culture report, which was ready by 48 to 72 hours. As you can see here, the organism is Klebsiella pneumoniae. The sample taken was patients, and the colony is more than 1 lakh colonies. As you can see here, the only sensitive organisms here, sensitive antibiotics is amikacin, minocycline, here tigecycline, and similarly the fosfomycin, ceftazidime, avibactam, and polymyxins. So here, again, the polymyxins were used initially and subsequently changed to ceftazidime, avibactam. Another thing we need to use in such cases is, since it's a pneumonia and the polymyxins do not achieve good concentration in the lungs, especially the mucosa, the surfact, the alveoli, nebulized colistin has to be used in such cases along with the systemic polymyxin. That's another thing that we need to know. So it's always better to combine systemic polymyxin with the nebulized colistin. So these are another few reports. This is a report where the ET secretion grew Pseudomonas. Commonly, if you talk about Pseudomonas aeruginosa, it is resistant. The tigecycline is inherently resistant. So, but in this case, it is a species. It's not a aeruginosa. That's why these are working. But if you see Pseudomonas aeruginosa reported, and if somebody is giving the sensitivity report to minocycline, tigecycline, and cotrimoxazole, there is an error. Do not use these drugs. Similarly, here in these cases, again, it's another MDR organism. So another case where there is a recent fracture followed by a fibular plating done in this patient who presented with pain, swelling, and pulsation from the surgical site. And there were two different cultures taken. And if you see here, these same organisms are a slight different sensitivity patterns. So if you see in this, piperacillin tazobactam was resistant, and another one, it's a sensitive one, but carbapenems are sensitive. So always make sure that you go through all the cultures and then only decide your antibiotic therapy. So in this case, the carbapenems were used and the patient got better. Obviously, he needed surgery and implant removal. So source control is important thing. Just simply treating the cultures doesn't solve the problem. You need to address the source all the time. Now, this is another case where there was a recent craniotomy. Subsequently, patient developed fever, drop in the GCS, and the CSF was tapped, and it showed the MDR gram negative as usual, the Klebsiella. So this is basically a post-neurosurgical meningitis with the resistant Klebsiella. Now, even if you see sometimes cefepime sensitive, cefepime can be used in such cases. Let's say here the ceftriaxone is sensitive. So it can be used depending on the sensitivity, because these drugs penetrate the CNS well. However, there you need to be careful because you have carbapenem resistance here, and very odd, you don't commonly see resistance mechanisms in Klebsiella, though possible, but it's you need to be very careful because there can be sometimes inducible ESBL which is not probably expressed for the ceftriaxone. So you, while on therapy with ceftriaxone, it might fail. So in such cases, sometimes you may have to use intrathecal drugs or drugs which have the CNS penetration like fosfomycin. Not many drugs. If you have a carbapenem resistance, then most of the times you don't have better drug than fosfomycin, or otherwise you may have to use only intrathecal polymyxin or colistin after the source control if there is any pus or anything there. So all these things we need to consider before finalizing the right antibiotic. So to summarize, whenever you assess the blood, any culture report, you need to see what is the sample, whether it's a sterile, non-sterile sample, what is the colony count in terms of non-sterile samples, when was the sample taken, what type of organism, whether it could be a contamination, colonizer, what is the colony count in those cases, any presence of devices, implants, what is the sensitivity pattern and possible mechanism of resistance to analyze what class of drugs are likely to work and not likely to work, what is the minimum inhibitory concentration, so that what is the right drug to be chosen, what is the concentration above MIC, that index where like we discussed a case where ceftriaxone and piperacillin tazobactam, all these PKBD principles have to be considered, and then only you can choose the right drug so that the outcomes are better. So I'll stop my discussion here. Thank you. I'll be happy to answer if there are any questions.
Thank you, Dr. Pratik. That was an exhaustive coverage regarding the interpretation of the report and the judicious use of antibiotic along with the antibiotic stewardship. So that's what is important. Now I open the session to, I would request Dr. Deepraj Singh sir to add a few of his inputs. Sir.
Yeah, good evening. Yeah. It was nice. You have presented it very nicely. But only my concern was, say, initially when the sepsis is being diagnosed, you have to start an antibiotic without waiting for the culture report. Some antibiotic you have to start it. How do you select that antibiotic under that scenario? You have gone through all these things. Probably each hospital has its protocol, or you judge it depending upon the type of the infection, the site of the infection.
Yes, sir. I mean, obviously,
yeah.
Topic of discussion was cultures. I really started
culture probably will be coming around 3 days minimum.
That's right, sir. Yeah. So what we usually do is, that's what we means everybody, based on the clinical presentation at the onset, if the
Right.
onset, I mean, if the diagnosis sepsis, obviously we want to know what type of sepsis it is, what is the
Right.
source, whether it's urinary infection, GI, or it's possibly if there is any bloodstream infection, primary or secondary. Depending on that, and obviously prior exposure to the antibiotic, what type of the patient he is, we choose the empirical drug based on the hospital antibiogram. So in
Hospital
such
program.
cases,
Yeah,
let's say if the patient we probably use carbapenems as an upfront therapy in most of the cases. However, if it is a community acquired sepsis, not probably requiring ward admission, you did not need to use the carbapenems. So it all depends on the patient profile and patient initial presentation and
So
underlying
empirically,
diagnosis.
you
What is the
start
underlying
with right. Okay.
Right. Thank you, sir.
Okay, Pradeep.
Dr. Veereshan, sir, your input, sir.
And one more.
Yes, sir.
To Srikanth. See,
Sir.
1 hour bundle you say, but is it possible in this 1 hour that all the reports, lactate reports, everything will be available in 1 hour bundle? 3 hours bundle, yes, I accept it. But in 1 hour bundle, by the time they take the sample and go to the lab and then get back, won't it cross 1 hour? Or your experience in your hospital?
Dr. Srikanth, you're muted.
Sir, 1 hour ABGs we can get we can get the
ABGs,
lactate
yes,
levels on
ABG you
ABGs,
can
sir.
get it. ABG you
So
can get it immediately. You can have even point of care ABG analysis also. But
sir,
lactate levels, serum lactate levels to confirm the level of lactate.
yes, sir. I mean, on ABGs we can have lactate levels, sir. So
Okay.
based on that,
Based on that,
we can take it.
Okay, sure. Okay, right.
Thank you, sir. Dr. Veereshan, sir.
Yeah, what is your hospital protocol, Pratik? For first, if you come across the patient, like depending on you already told that depending on the system, the infection is involved, and type of antibiotic, what is the hospital for GIT, for urinary tract infection, or with diabetes? What are the usual protocols your hospital is following till the culture report comes? First line of antibiotic.
So, depending, let's say if it's a urinary infection, simple urinary infection where patient is having possible, let us say, pyelonephritis, and it's a hemodynamically stable patient who probably needs a ward admission, no past history of antibiotic use. In such cases, something like BL-BLI combination, because most of our urinary tract infections are caused by gram-negatives, which are ESBL producers, nearly 70% of them. So basic cover is probably something like ceftriaxone sulbactam or piperacillin tazobactam for a stable patient. However, if the patient is very sick, hypotensive, tachycardic, requiring possibly an ICU admission, then carbapenem. Similarly, if somebody had recurrent UTIs or recent use of BL-BLI drugs, probably they may harbor even the carbapenem, these resistant organisms to these BL-BLI. So in such cases, carbapenems are used. Similarly, let's say if it's a community-acquired pneumonia and if it's a lobar pneumonia, otherwise healthy host, no respiratory pathology in the past, probably in such cases, ceftriaxone is good enough. If you don't have any other pathology, if you are suspecting, let's say, pneumococcal pneumonia, we hardly come across any resistant pneumococcus. So in those cases, ceftriaxone is good enough in a way. However, if it is same time, it's a COPD host prior respiratory exacerbations, you possibly have a colonization with gram negatives. In those cases, you need to cover for the gram negatives as well. So in those cases, again, maybe sometimes piperacillin tazobactam or carbapenems, depending upon the host profile, sickness, all those things.
So will you concentrate anything on the fungal infections in the first line before the culture report comes?
Sorry, sir. First, fungal. Okay. Sir, usually, most often we don't see the community-acquired infections, fungal infections. I mean, fungal infections, when we say the report, let's talk about yeast or yeast infections. Let's say Candida It's usually a infection that happens in the hospital while in patients who are on multiple antibiotics, possibly after the GI surgery or pancreatitis, lines, all those things. So community-acquired infections due to Candida, very unlikely. So usually we don't consider that. Yes, sometimes if patient being referred to another hospital from another hospital and all the risk factors, yes, we have to consider. So unlikely for the Candida organisms. Second thing, other mold-related infections. Yes, Aspergillus, mucor, these are all possible, but these are not as common infections. And then you need to have a tissue diagnosis, and they are not immediately life-threatening, except in mucor, where if there is angioinvasion, let's say in bloodstream infection, or if you say renal mucor, but they are all fulminant and very less common infections to consider. And each case needs to be individualized. So, community-acquired infections, usually we don't give empirical antifungals.
Okay, thank you.
Yes. Thank you. Dr. Pavani, madam, your inputs, please.
Yeah. Srikanth, I just wanted to know what are the... what is the role of immunomodulants like urinostatin and others in sepsis? Recent guidelines are there?
Madam, there are no guidelines regarding the use of those immunomodulators, madam, like urinostatin. It is just the antibiotic which needs to be done and the 1 hour bundle which needs to be started, madam. There are no specific guidelines or no recommendations have been given till date regarding those agents.
Immunomodulators.
Yes, ma'am.
Okay, but there are certain studies where it has been used.
There have been studies.
Because they are quite expensive. So should we use,
yes,
or
madam.
should we just?
I mean, in my limited practice, it has not shown of a much benefit, madam. It is only antibiotics and the adequate source control along with the fluid resuscitation, hemodynamic management is what plays an important role.
And role of glutamine?
No, madam. No other drugs, no immunomodulation drugs have shown a benefit. There have been very few studies. There are lots of studies which have shown no beneficial effect on in sepsis.
Achha. What is your experience with ECMO in sepsis?
I have no experience with ECMO.
Yeah. Okay.
Right. Okay. Thank you, ma'am.
Thank you.
Dr. Pratik, there is a question for you. How frequently in your practice do you do anaerobic cultures, and what are the indications asking specifically for anaerobic cultures?
Okay. We don't do anaerobic cultures commonly. We need to do anaerobic cultures only when there is a, let's say, perforation peritonitis, or there is a certain such infections, pelvic abscesses or things like that. So in only those cases, you need to do the anaerobic cultures. And again, you need to be very specific. Let's say blood culture. Let's talk about the anaerobic blood culture. We don't commonly come across the anaerobic blood cultures being done. Again, most of the urinary infections and all, we don't see the anaerobic organisms being the culprit organisms. So we usually don't do. And if you talk about the non-blood samples for the anaerobic culture, you need quite stringent measures for the sample not to be exposed to the air. Like you need to have the carbon dioxide jar and things like that. The sample should not be exposed. They should be collected and immediately transferred to the lab so that it is kept in a incubator without wasting time. So we don't routinely do, but yes, since the cost is not much higher, there is no wrong side doing anaerobic culture. So what you can do is, important thing what we need to ensure is we are doing adequate sampling of cultures. So sending one sample in a septic shock patient who is going to the ICU is not adequate. If you increase your volume of blood culture, the yield will be better. In those situations, probably you can increase the yield by adding one aerobic and one anaerobic. That makes more logic. So you need to send that. You can still pick up all the organisms even in anaerobic media. So even you're not going to lose out. Let's say you're growing a gram-negative in aerobic. If you put the blood in the anaerobic also, it is still likely to grow there. Probably a bit early, but there is no always need. And if it is possible, you can always do that. There is no harm in doing
that. Very well presented. Very well presented, Dr. Both of you. So congratulations. Aditya also.
Thank you, ma'am. Just to add, madam, regarding the role of ulinastatin or other immunomodulators, what we have found, there is no direct evidence as such saying that they should be used. But what out of clinical experience, some experts have suggested is whenever your patient is in a septic shock, where obviously you have done the septic bundle, the source control and other things, as a part of a patient is in cytokine storm or inflammatory syndrome, probably this will add, like it could add you to get the cytokine storm down so that your antibiotic response is better rather than harboring him with the polypharmacy of multiple antibiotics and then making it more antibiotic resistance. So definitely there is a role in patient in a cytokine storm commonly seen in the COVID era, but it was prior documented also, post bypass surgeries or frank septic peritonitis. So definitely there is a role. They are immunomodulator, but the only thing is they cannot be routinely used, and because one thing is abuse, another thing is it's a high cost. So probably with a proper team approach, things could be utilized in a much better way. So that is one thing I just thought I would add on. Dr. Ramakrishna sir. Dr. Ramakrishna sir, we are waiting for your inputs. You are unmute, sir. You have to unmute.
So thank you. When you suggested these topics, a little bit discussion went on. Whether, like we were worried about, some people may criticize these topics are, not much related to anesthesia. But I said, Aditya, go on, because I worked in intensive care in UK for a long time. I know how it is useful, these two topics. So ultimately, these two young talented speakers presented very well. And I appreciate Dr. Srikanth and Dr. Pratik Patil. Well done.
Thank you, sir.
So it was a fruitful discussion and it went very well. And we look forward to see many talented, young speakers to speak on a variety of topics. Thank you.
Thank you, Ramakrishna sir, and thanks to the ISC team, Telangana, as well as the ISC National Office bearers, and all the seniors here for guiding us. Yes, it was a rough topic, but as we said, we were totally more into the academics, and we wanted to focus on the areas that are not more concentrated in the regular teaching, so that the postgraduate as well as the consultants speak. So my only request to everyone would be that not only whenever you go through ICU, please go through the culture report, try to interpret it, try to understand what they are trying to say. And as Dr. Pratik was suggesting, what is the organism? Is there the tissue penetration of an antibiotic there? These are few of the questions that you need to take yourself when you call yourself an intensivist, rather than depending on any other consultant. So that gives you a more meticulous and a comprehensive care to the patient and increase your self-confidence also in treating a complicated case. So at the outset, I again thank all the ISC team and the seniors here. And I thank both the speakers for doing a brilliant job. Though it was a dry topic, a vast topic with a lot of gray shades, they could come out with a definite guidelines and much more clarity. So I thank you both for all the things. At the outset from the ISA, I thank everyone for attending this webinar and making it more interacting. Thank you from my side and good.
I can say actually it is guiding to all the consultants. It's a basic guidelines in critical care, like how to interpret the report, how to analyze it, how to start with the septicemia treatment. These are the things. Sometimes it's a gray areas for a regular anesthetist. Probably they are out of the antibiotics are out of their field basically, but now we are into the critical zone. Everybody has to know it. Youngsters are very much in that, and like faculty, we do have some problems in interpreting. So that's why it's eye-opening for us. Definitely, it is not a boring topic. It's a very good topic and precise and informative. Thank you.
Thank you all.
Srikanth
So
and Pratik.
If there are no questions, I would just a sec. There's something in the chat box that has popped. I'm sorry, Dr. Pratik. There's one last question to you. What is the Conley count required for starting antibiotics in an immunosuppressed patient?
Okay, so see, it depends on what is the culture. Let's say if it is blood, any sterile site culture is always significant if you have suspecting infection in that given area. So there is no question of any colony count in sterile samples. So question of colony count comes only when there is a non-sterile site, let's say urine and ET secretions or sputum, because it may have a normal colonizer. So that's why unless the colonies are significantly high, then only you need to treat them. Now coming to the immunosuppressed hosts, again, it depends on whether you are suspecting the infection in that particular site. Let's say immunosuppressed host itself is a broad term in general for us, let's say. So it can be a neutropenic patient who is, let's say, on chemotherapy and all. In that case, if there is a cough and something growing in, then probably I would still treat it if there is a sudden infection doubtful. Because let us say if it is a neutropenic patient and he has certain colony count, and the problem here is he may have mucositis, he may have breach in the normal mucosa. So even if there is a colonizer, he is high risk of infection and he may not give us time to respond if he gets into the systemic sepsis. Or there is a lot of gut translocation in those cases, or transmission or spread of infections from the mucosa to the bloodstream. So in those cases, I may not look into the colony count. If there is a febrile neutropenia, let us say, I will treat it. However, let's say if there is a patient, let's say old renal transplant, is on stable immunosuppression and he is growing something in the sputum, however, no signs of lower respiratory tract infection, no systemic signs, I may just leave it alone. So immunosuppression, again, we need to thread it further, what it is, what type of immunosuppression you are looking at, whether it's a acute immunosuppression, chronic immunosuppression, what species, what organism, what site. So all needs to be individualized based on the case.
So I think that solves all the questions in the chat box. So that was really an exhaustive coverage. And again, at the outset, before I leave, I thank the Dr. Ramakrishna sir, Dr. Veereshan sir, and Dr. Satnarayan sir, Pavani madam, and Deepra Singh sir for allowing us to take the gamble of taking such a great topic. But as we said, we are more focused on topics that are not routinely covered and that are useful by and large to all in a significant way. So thank you again to the speakers for a wonderful job and our lecture too. So we'll look forward for further more academic schedules. Thank
Thank you, Aditya.
Thank you, sir. Thank you, everybody.
Thank you, everyone. Thank you.
you, sir.
Thank you.